Wrong. Nothing coming up here.
Like O6, the IC-OSA or OS-CAR is another scoring for surgery training scoring for these residents, which Dr. Sunil will be covering now.
I thank you all. Thanks Meenakshi for putting up such a brilliant program, and Prashant and others. I have to tell you this, that we have been working a lot about developing the Oscars in the initial stages, and then looking at other rubrics and other evaluation methods. Also not only for the postgraduates but also for us ourselves as continuing professional development, because as we go ahead we realize that we passed out doing different kind of surgeries, and then we ended up, so I would say that this is probably something that you need to do for ourselves as well. So, my disclosure is that I do conduct courses for ICO where the attendees pay. So that's my attention grabbing slide. So this is what has happened on March 8, 2017. A doctor watched surgery on YouTube before he went and did the surgery. So his only training for the surgery was that I saw one and I tried doing that. How many of us do that? Has anybody seen anyone do that? I have seen a couple of colleagues of mine do that. They've never done a surgery before. They've never undergone a training program for a particular thing, let's say. How is it that people end up doing their first LASIK? I have seen one. I haven't entered into a program and I started doing my LASIK. So something like this is something very dangerous, and so it's probably important to have a structured program with a structured report written by somebody saying that you have competency in all of that. So my objectives here: enumerate 4 objective tests for surgical competence assessment, use ICO Oscar for own students, state 4 differences between a direct observation where we are actually standing there and a video observation where the surgery is recorded and then you are looking at it, and state 2 pros and cons of video observation. The pre-test, I mean, which one is better? What do you think? Direct or video observation?
Direct. Direct.
Direct?
In
okay.
the sense you can at least intervene and take over, or you know.
We'll come to that. What are the 4 objective methods of assessing surgical competence besides Oscars? How many of us are using Oscars already? 2, 3. Anybody else not using Oscars? What are the 4 advantages of ICO Oscar? We'll come to that later. And does surgical recording of patient's video for teaching purposes need his consent? And what are the legalities involved in it? We'll come to these later on. But the whole thing that started it all was the resident surgeon's phacoemulsification learning curve. We had a lot of complications when phacoemulsification started. So we had, to a certain extent, I have one of my friends saying that the retina specialty became much more sought after phacoemulsification started. So this is what started the Oscar thing. We know that there are key tasks in cataract surgery. Now let me come to what I'm trying to say is a little going a little offbeat from Oscar. Oscar has got 19 steps recorded in it, and some people say that it's not possible to watch every step and write down something right there at that particular time. So you look at 4 key steps. The key steps: incision, the CCC, the phacoemulsification, and the irrigation aspiration. Now most of us, when we do the unstructured thing, we first give our residents a tunnel or something like that, and he doesn't do it well, he doesn't go on to CCC. So these are where we, what we call as milestones in the progress of a resident. So when we talk about milestones, how many of you talk about, let's say, how many tunnels should the resident do better before he goes on to capsular access? Do you do that? 5 tunnels, 2 tunnels, 4 tunnels, better before he does this thing well. How do we arrive to at that particular number? What tells you that? So what I'm trying to say is that we are very subjective in our assessment of the resident. We see 2 tunnels and I say, I think he's fine. Or we'll end up saying that I'm not very happy with this tunnel, so he doesn't progress. So this is what has led to the present situation where residents do not do a single case of phacoemulsification before they leave. So if I have something objective and which is structured, and I can tell him that this is exactly what you're doing wrong, just like the O6, then we probably need to give lesser steps and then end up doing a complete surgery better. So there are 3 concepts that we talk about: progress rate, how this resident is progressing, the average progress rate, and the increase in the progress rate over a period of time in terms of percentages. And what you look at, I mean, I'm not talking about when we're talking about Oscars or a structured examination like she spoke about the O6, we are looking at not just phaco with IOL. So you don't aim at something like 100 phaco with IOL, trabeculectomies 4 or 5, dicrocystectomies, DCRs, pterygium surgery. I mean, in my center, I realize that I do a lot of oculoplasty. So there's a skew. This is one individual, this is resident B, who ends up doing quite a lot of phaco, doesn't do trabeculectomy at all, does a lot of pterygium, does a lot of turbinectomy, does no vitrectomy, does no DCR, just does a lot of turbinectomy. Because that's what I end up doing. Do the turbinectomy, the rest of the DCR endoscopically I will finish it. So if you monitor your resident in such a way that you make a chart and you look at your bias in terms of what types of surgeries, you might be able to equally balance out the resident. The first thing that was written about in terms of objective evaluation was the OSS, which was published way back in 2001, which was objective assessment of skills of intraocular surgery, not a particular surgery. There was a, is this visible? So there were few things that we looked at was respect of tissue, the time and the motion, is a resident moving his hand too much, knowledge and handling of instruments, the flow of the operation, the use of assistance, and the knowledge of particular procedures. And then you looked at 1, 2, 3, 4, 5. Your 1 was defined, 2 was between 1 and 2, 5 was defined, 4 was between 3 and 4. So frequently used unnecessary force. So you looked at respect for tissue. This was for everything in general, the surgical handling in short. So that was OSATs. After the OSS, then Harvard came with their charts here, where you had training level, you had to have the same procedures as we spoke about in 06, identified himself, identified options, described the procedure, identified risks, identified benefits. So this is what you do before the resident actually goes into surgery. Then you look at the same OSS kind of a thing on cataract in specificity. And you look at, now this is from the University of Iowa, you look at the novice surgeon, the beginner, the advanced beginner, the proficient and the expert. So the proficient is a two-handed surgeon, an advanced surgeon is an efficient surgeon, and you look at expected behaviors from them. The desire to learn is there in the novice, demonstrate microscope use in the beginner, and you look at advanced beginner, demonstrates 5 cases less than 45 minutes. Then you look at proficient, demonstrate 5 cases less than 30 minutes using both hands. And then an expert is able to do even small incision, small pupils and other techniques. So you defined these 5 Dreyfus types of residents. So that's the Dreyfus model. So there's a novice, a beginner, an advanced beginner, proficient and expert. And then we started with what was called as OSACs, which was the initial part which I showed you, and that grew into the Oscars. So OSACs was what was the basis for the ICO Oscar for its construct value, because OSACs constructed these particular parts and then Oscar picked it up and validated it. So we sent it to people and said, can you do all of it? For me, when you ask me to validate it, I can validate only 4 steps of Oscar. So I end up checking for tunnel, for CCC, for phaco, the emulsification and cortex aspiration and IOL, 4 or 5 steps. So when you come to ICO, the Oscar, it is the same thing like the O6. So you have the surgery deconstructed into multiple parts. So you start with draping, incision and paracentesis, viscoelastic, appropriate use and safe insertion of the viscoelastic, capsular excess, commencement of the flap and follow through how it goes on, capsular excess, formation and circular completion, hydrodissection, and then you look at novice, beginner, advanced beginner or competent, and you start with putting the scores as is able to, unable to start draping without help, the score is at around 2. And as he goes more and more competent, the score increases. And if it is not done, the score is 0. It's done by the preceptor. I mean, I'm sorry, I'm not going to allow you to do that. It's going to be 0 there. Then you go on to phacoemulsification probe and instrument, second instrument handling. Then you look at nucleus sculpting, nucleus rotation, nucleus cracking, irrigation and aspiration, lens insertion and wound closure. And all of this is charted out and broken down into what a novice would do and what a expert would do. Then you have global indices. What is the wound neutrality? Was the eye positioned centrally when the microscope was being seen? Conjunctival tissue handling. Intraocular spatial awareness, you know how deep or superficial he was going, iris protection, and the overall speed and the fluidity of the procedure. And you rank them based on each of their competency, how they do. They do it like a novice would do or like a advanced expert would do. So we come to two things here. Oscar was initially designed for a direct observation. Direct observation of procedural skills, the most commonly used. In this method, an advanced trainee performs a procedure on a patient and an experienced and knowledgeable accessor observes the trainee's performance, right? And so this provides a face validity. I've actually seen him. But the shortcomings are multiple trainees cannot be accurately assessed, and growing number of residents, this is becoming less feasible. The observers cannot be masked. So I have a particular bias against a particular resident. I am not masked against him. And additionally, while acutely being aware of being observed, even I do bad. So if you were to tell me that you are going to do an Oscar on me, my scores are going to be like that of a novice. But if you are telling me that you are not going to watch me, my scores will probably be a little better. So we go on to video recording. So what does everybody think about it? Is this, so look at videos and you practice as a person to do your grading based on. So I'm taking different surgeries so that I present to you that your residency is not only about cataract, right? So is this, do you see tremors? Do you see the fluidity of the procedure? Do you see hesitancy? The draping is not done properly. The drape is all this thing. So on a scale right from 1, draping, it would be at roughly around score of 2. And then going all the way around, so the total score would be much less. So we came to the next aspect of video observation of procedural skills. Now this was done first for trabeculectomy, and this was presented by Hassan Paur. And video observation in which the trainee's performance is recorded and later evaluated by the assessor. The method provides the assessor with adequate time. So one of the more difficult problems is that you have a very short time and you are supposed to write down breakup of everything. So he's done a CCC and you're supposed to write down whether he used fluidics properly, whether he initiated it, whether it was circle. So it's very difficult for the surgeon to, the assessor also to think. The video assessment makes it a little better. The method is more systematic, can be blinded, and it also allows the residents to participate in the assessment process and compare their procedural skills with other trainees. So this is something that is not possible in direct observation. Now we go further to a man-made observation versus a machine software. So you record your surgery and you put it into a machine and you look at various steps, but what is important that the complexities which are involved here, there are sometimes that multiple instruments are there and they hide the tremor of one instrument. There might sometimes be blurred images. So videos may not exactly be the right answer. You sometimes use tracking strategies. We tried using the tracking strategies to find out if there are tremors, but sometimes it's not the tremors of the surgeon, but it's the tremors which is there during the recording. Now let's practice a little bit on this. We are talking about draping here. What would you what level would you put this as? I'm not going to show you the 4 parts. Just make an assessment because you're not going to have an opportunity to have the Oscar. So what would you label this as? A novice? A beginner? Advanced beginner? Expert? Novice. So this is our first year resident trying to drape. Is struggling with the drape. What about this? Yes. The painting. Is there something you want to give as a feedback here? So something you may not notice at that particular time. The painting is happening from the medial canthus out to the lateral canthus. So by chance there's some muck at the medial canthus is being spread all the way around. We initially go from the other. So there are some things which might occur to you when you watch the video and you figure out that something was not addressed. That's an endoscopic DCR, an initial cut being made. This is being recorded, an initial cut. Where would you place this? As a novice and beginner? Advanced beginner, expert or proficient?
Maybe advanced beginner.
Advanced beginner, because that's very smooth cuts and there is no movement of the scope. There are no tremors there, making nice cut. Thank you, that's me. So that brings us to a important topic that a lot of my colleagues, they record a small shot of the resident and then they WhatsApp it to me or they telegram it to me or they Snapchat. You have Snapchat goggles, and many of the surgeons even Snapchat. So Snapchat to each other, and has anybody used Snapchat? Has any of you all used Snapchat?
My PGs use, and I'm aware of it.
Yeah. So the advantage of Snapchat is in the legal era, if I send you a video or a picture, the minute you have viewed it, it disappears. So it's not stored. So that's why it is very popular with youngsters, right? So even Miami, many of the doctors have started Snapchatting and sending it. So I want to show and I want to ask Shakeen sir, what did I do wrong here? And I can Snapchat it to him. He can tell me what I did wrong, and then the video gets deleted. So this is becoming more popular. But then you are also getting medical legal cases where without consent. So the most important thing, what I'm talking about when you are video recording, and I'm proposing video recording, is that the consent of the patient is extremely important, because an employee patient of a particular hospital in Washington has sued the hospital for being photographed without her consent. So video recording is something that will definitely be worse. So summarizing, objective scoring of residents can be done by Oscars the best, because that is something which has been validated so far. So it has been sent across to people. We have looked at the scores. One person has scored a particular resident, the other person has scored the resident. The scores do not differ much. But balance needs to be maintained in terms of what surgery we are scoring. So you have Oscars for phaco, you have Oscars for SICS, you have Oscars for trabeculectomy now, for lateral canthal strip. So you need to do all those Oscars together. So you're going to be able to do 1 or 2 Oscars only in a month or year probably of one particular thing. So you need to keep a balance there. And if you're going to do so many Oscars and you have many residents, you're probably going to need video observation. And HIPAA, privacy and consent issues need to be dealt with.